would like to thank the organizers and especially Mario for inviting me. It's great to be back in Switzerland and great to be back in Bern. I haven't been to this conference before. Für mich, der Schweiz und Bern ist Sommer, Orientierungslauf und danach ein großes Bier bitte. So I'm going to talk about two things. First, I'm going to talk about putting science into action. And that is the most rewarding thing I've ever done. And you can't do that without mentioning my young, energetic, and very smart former PhD student, Soren Sko. Because without our amazing collaboration, there would never have been a GLAD. And the second thing that I'm going to talk about is a little bit about hip patients, because this is, after all, a conference with focus on the hip. So, GLAD, what is that? Well, it started back in 2013, that's 5 years ago. This is a not-for-profit initiative which is based at a university. And it is trademarked, and that's just to protect the quality of the program. And why was it started? Well, I felt like this little person up there screaming, exercise works for knee osteoarthritis. And I had had the opportunity to sit on clinical guideline committees in many countries. And already back in 2003 in Sweden and Norway, this was the first recommendation. But at that time, the evidence was not very solid. But with time, there were more and more randomized controlled trials, and in 2012 there were more than 50 randomized controlled trials showing that exercise was good medicine for people with knee osteoarthritis. We discussed with healthcare authorities for many years, and we got to know that they thought this was a really good idea to follow clinical guidelines, but it won't happen. And it won't happen because of this guy sitting here. And he actually represents politics, stakeholders having very different agendas, organizational issues within the healthcare sector, and financial incentives. So we became researcher activists, or whatever you want to say, because we decided to do it ourselves. And what we did was that we built our program up on experiences from Sweden, where they started something called Better Treatment for Osteoarthritis back in 2008. And that program is really about patient education. So they provide patients with patient education, and they also encourage them to become more physically active. But when you look into their registry, you can see that actually it's only 30% of the patients in Sweden who have had 10 or more supervised exercise sessions. And we know, based on the literature and evidence, that you need 10-12 sessions at the minimum, and you need supervised sessions to get better effect than home exercises, for example. So we were not too happy with that. So when we started our program, we decided to add an exercise program. And we use a neuromuscular exercise program. And that is not because that necessarily is a better exercise program than any other exercise program. It is because it's an exercise program that we are very familiar with, and that we have used in many studies, and that we also have tested in people with very severe, or what you would call bone-on-bone osteoarthritis, and we know that it is safe and feasible for these patients. And that was important for us when we wanted to roll something out nationwide, that it is safe and feasible for everyone, when we wanted to put that tool in the hand of many clinicians, where maybe all are not used to treating this type of patients. And we can see when we do this that actually 85% of all patients in our program have had at least 10 supervised sessions. So what is neuromuscular exercise? Well, those of you who work a lot with sports, you recognize the principles, because this program builds upon the same type of programs that we use to rehabilitate people with major knee injuries. And it is a treatment or a therapy that is good for the osteoarthritic joint. And we work a lot with alignment, movement, quality. We've seen lots of films and movies prior today about what poor movement looks like, poor movement control. And we use the same principles here. And it's about appropriate load, not too little, not too much. And it's about progression. Progression is really important also for these people. And it is different from strength training, where the aim is to improve muscle strength, and it is different from aerobic conditioning, when the aim is actually to improve your cardiovascular output. So these are different types of exercise. And our approach is that we start with 6 weeks of neuromuscular exercise, and the whole idea is that when patients have increased their confidence in their osteoarthritic joints, they are more able to go on with the type of physical activity and exercise that they enjoy doing. And this type of program really is more aimed at the sensory-motor deficits that there are and functional instability, much like in knee-injured patients. And if you want to know more about this, you can find Ewa Roos. She's here somewhere. She's the true expert on neuromuscular exercise. So in the program that we use, there are several different components with different focus, but what goes through all these components is the focus on movement quality and good alignment. This is one example of a neuromuscular exercise which is adapted to middle-aged or older population. And when we do it in GLAD, we would provide different standardized levels for progression. And for the new or unexperienced clinician delivering the neuromuscular exercise program, they maybe stick to these 4 levels. But for the more advanced physio, you know that you can individualize and you can vary this in very many ways to make it fit your own person and challenge them so they improve with time. We also make sure that the patients themselves note what level they are exercising on every time, every week. Another thing that is incorporated in this exercise program, and that's also something that you've heard many times today, that's a pain monitoring system. And there is actually a reference there. This is from 1997. And we tell patients that it's okay to exercise with pain. But we also teach patients to manage and monitor their own pain, to decrease the anxiety, because people get very anxious if they have pain. They're very worried that they're destroying something in their joints. So they need your support, and you need to hold their hand and give them feedback. And they need simple pain rules. And the 2 pain rules that we use is that after exercise, pain should be acceptable, and the day after exercise, the pain should have subsided to their normal pain. That does not have to be 0, that can be 2, 3, 4, but it should be their normal pain. If you follow these 2 rules, it is safe to exercise and they can progress. So very deliberately, we have patients register both their pain and their progression. And I'll come back to that. But what we can see is that you can expect to get a pain flare. This is the difference from pain before to after exercise. So you can see that you can actually expect an average pain flare of about 0.6 during your first exercise session. And this is not because it's dangerous, it's because these people are doing something that they are not used to doing. And you can see that this pain flare decreases with number of exercises. That's a very good message to give to patients. So I think, or we think, that teaching the patients to monitor their load and their pain is actually part of self-management and a way of empowering them to take control over their own treatment. And we think that it may help them to continue to feel empowered to exercise. So GLAD is many things. The first thing is that we bring clinicians to our university for a 2-day course where clinicians learn about osteoarthritis and they learn about treatment for osteoarthritis. They also learn to deliver patient education. They learn to deliver the exercise program, and they learn to enter data into clinical registry, much like Mariana Riesberg told you before. Clinicians then go home in their own clinic where they deliver patient education according to a program with PowerPoint slides and all that, and an exercise program. If the clinician finds that my patient needs some manual therapy to improve range of motion, you can do that on top of it, but this needs to be delivered as the core component. And eventually, data is collected in a clinical registry, and that has been key to the success of our program. Because if we had not been able to show the effects from this program, it would not have been the success it is. So who are then included in the GLAD database? Well, one have to recognize that this is a unique database of people with hip and knee osteoarthritis that are treated in primary care. And in many countries, there are no such data of these patients because usually we pick them up when they have surgery. And there are, of course, both strengths and limitations associated with this. If you work as a physiotherapist, it's great because you can very much generalize it to the patients that you meet in your clinic. But it's not population-based, and you need to take that into account when I will show you some results. There is also, of course, a selection because in Denmark, visiting the general practitioner or having surgery is free of cost, but you have to pay to see the physiotherapist. So, of course, there is a selection in people joining this program. So what are the results? So I'll share with you some results from our annual report in 2017. We recruit about 10,000 patients a year into the program, and I got an email this morning saying that we now have 38,000 people in the registry. And there are about 350 active clinics all over Denmark delivering the program. And it looks like this. There is a little map that you can click on to find a clinic. You can actually write down your address or your work address, and you can search for clinics that are close to where you live or work. And there is a wide variation in age of people who participate in the program. But as you can see, most are overweight or obese, and that goes both for hip and knee osteoarthritis patients. But the typical patient is a 65-year-old woman with knee pain. And if we look at the results, we can see that there is on average a 25% pain relief. 1 out of 3 stop taking painkillers, and that goes both for paracetamol, NSAIDs, and opioids. They increase their walking speed with 10%, and their quality of life goes up. You have to remember now that this is not a randomized controlled trial with a research group. This is real life with data collected in physiotherapy clinics across the whole country. And what is very interesting is that we can see that the good results persist at 1 year. That is very interesting because it's a short intervention. And we actually don't know why we see good long-term results. You can just speculate. It may be the combination with the patient education that we try and make a huge effort to empower patients to continue. But there are some hard outcomes that are interesting to see. For example, that there is a decrease in sick leave if you compare the number of people on sick leave the year after GLAD to the year prior to GLAD. GLAD is a success not only in Denmark, but across 4 continents. So it started in Canada in 2015, and they have now trained more than 700 clinicians, and they have 1,900 patients in their registry. And what is interesting is to see that you can actually adapt this type of program for different healthcare settings. And the same thing was done in Australia in 2016, and we're fortunate enough to have Kay Crossley, Joe Kemp, and Christian Barton, the Trek guy, to work with this in Australia. And if you're curious about their expectations or their experiences, you can just go and talk to them. I heard from Joe that they had been teaching 11 courses this year in Australia, and that they have 700 physios on waiting list to take a course. So there is this huge demand because the huge number of patients suffering from osteoarthritis. And China is the most interesting of all the countries because that is so different from all the other countries. So this is Chang Liu and Kim Wao and the group that is running GLAD in China. And what is interesting is that they are orthopedic surgeons who work with their nurses in delivering this program. So we have had these orthopedic surgeons train with us in Denmark many times, and we have been to China many times. And they are committed to deliver exercise therapy as an alternative to surgery in China. So there are different cultures in different countries. And there are no physiotherapists treating people with musculoskeletal problems. So they are now building up an infrastructure with, for example, exercise facilities. Maybe there will be a GLAD Switzerland, I don't know. We had a meeting yesterday, and if you're interested, you should contact Omega Huber to get on board, because the success of GLAD very much depends on that this is a bottom-up initiative. So it is actually the clinicians who are responsible for the success. So in Denmark, many clinicians, they support and they market the program locally with their physicians, and that's just the way it should be. So it needs engagement from all clinicians to make a thing like this work. It's a common effort. So in summary, it is feasible to deliver treatment according to clinical guidelines in clinical practice. The data shows that it is effective also in long term. And it's actually a way of improving the quality of care for these patients. And you can adapt and implement this type of initiatives across countries and healthcare settings. Thank you.